For children who are less than 6 months, we do not do MOAC measurements. It is not helpful. We only do MOAC measurements for children who are more than 6 months of age. So in those less than 6 months, we do their weight for length, or we check for presence of edema. For children who are 6 to 59 months, we do their MOACs, we do their weight for length, and we also check for edema. So for children who are 5 years to 19 years of age, we do not use weight for length. We use their BMI scores, but we can also do their MOACs, and we check for presence of edema. Next. So this is an extract from the basic pediatric protocols. Well, this is the 2006 one, but we have one of 2023 that is available. It's not very different from this. So it has the length. When you're using these charts from the basic pediatric protocols, you have to be careful to make sure that you use the correct chart for the correct sex and for the correct age. So there is one for 0 to 24 months, and then for those who are over 24 months. You have to be careful that you are using the right chart, otherwise you may label the child malnourished when they are not malnourished, or you may say they are okay when they are actually not okay. Okay, next. So when we talk about clinical assessment, of course, this is the simplest and the most practical. It's the simplest. If you have not used a weighing scale before, especially, Lois will tell you, the 2-in-1 weighing scale, you will not know what to do. If you have not used the height board before, you may never know what to do. But clinical exam, it's simple. You just see the child and you know, if you know what to look for, that is. And in your clinical exam, of course, emphasis should be on visible wasting. So obviously the child looks wasted. They have when you look at their bums, at their gluteus, they have flabby skin. So that should tell you that this child is wasted. Or look at their feet for edema. Press to see if there is pitting edema. The edema of malnutrition is rarely unilateral. It will always be, and most of the times will be bilateral. So bilateral pitting edema in malnutrition is what you're looking for. In clinical examination, you have to pay a lot of emphasis on hair. Our child had brown hair, though it was not sparse, but most times it will be sparse, silky hair that is soft and easily pluckable. Look at their angles of their mouth for chelosis. Look at their gum. Look at the nails for signs of iron. So in doing the general exam, you're looking at the signs of micronutrient deficiencies, which is usually associated in malnutrition. So in the nails, you're looking for signs of iron deficiency. On the skin, you're looking for signs of zinc deficiencies. In the eyes, signs of vitamin A deficiency. On the tongue, all these parts of the body are telling you something that is deficient in this child. Not all of them will have all the deficiencies, but at least look for them for every child that you see. Be on the lookout for medical complications that occur with malnutrition, hypothermia, hypoglycemia, ulcerations in the cornea, severe anemia, dermatosis, signs of heart failure. So all these things, you have to be on the lookout for them. Next. So the next is these are really diagrammatic representations of children who have clinical signs of malnutrition. The first is a child who is wasted. There are pictures that compare this child to normal children, but this child was really, really wasted. The second picture there is looking at pitting edema. I don't know if it's clear to everyone who is looking at it, but when you press, clearly it leaves a dimple in the child's foot. In the eyes, you're looking for corneal ulcers, you're looking for pus, you're looking for corneal ulceration, you're looking for bitter spots, you're looking for pus formation, any of those things that can really point you towards vitamin A deficiency. Then on the skin, so dermatosis, please don't find this child and think this is a child who is bad. So the children with dermatosis, sometimes it looks really bad and it may look a lot like a burn. Next. So I'm going to go ahead and talk about the laboratory evaluations. For all these children, we do, so we look for infection markers because children with malnutrition may not be able, we already saw their immunity, they have secondary immunodeficiency. So they are not able to mount response to infections like other children would. They may not have a fever. They may have instead hypothermia, or the temperature may be normal, but when you have all these different infections coexisting, malaria, UTIs, sepsis is very, very common. They may have a pneumonia, TB, like we saw in baby who was shared in the case scenario. So you do a complete blood count to look at their HB, but also red cell indices, because you may have nutritional anemia in these children. Levels of pre-albumin and albumin really to help you gauge whether you're having adequate short and long-term dietary intake. This is before treatment and then after treatment. Cellular immunity, you may do this if resources allow. It's not very cheap in our setting, but children tend to have very low T cell counts because of the thymus atrophy that they have. Then vitamin deficiencies, because they have issues with absorption in their guts because of edema, but also just erosion of the gut due to the illness. Next. Other important tests, of course, they are RFTs. They have hypokalemia, hypophosphatemias, especially in refeeding syndrome. Sodium is less in these children. They have sodium is reduced, especially in those with edematous malnutrition. You should not always treat their low sodium, because when we correct the edema, their sodium levels tend to return back to normal. Their BUN may be low, but you also do other electrolytes, sodium, like potassium in these children as well. And you can do their zinc and magnesium, but not very commonly done in our setting. Thank you for joining in. I welcome questions and reactions. Thank you.
Thank you very much, Dr. Esther, for that wonderful presentation. If you have any questions, please keep them coming in the Q&A section. As you were presenting, there is someone who asked why you choose to use the non-dominant hand for taking work.
Okay, thank you for that question. So we prefer to use the non-dominant hand simply because when the hand that you use, so you tend to obviously have more muscle use in that muscle. So you want to use the less dominant hand because you're sure that the child has not really been using it too much and the muscle mass may still be intact in this child. Thank you.
Thank you very much, Dr. Esther. Next on the agenda is our presentation by Dr. Connie Baluka. Yes, Dr. Baluka, please take over. Yes. That's it.
Okay. Good afternoon, everyone. I'm called Baluka Connie, and I'm going to basically look at the emergency approach to a child with severe acute malnutrition. So as you go through as we go through the presentation, you'll realize there are certain aspects I have not touched, because by that time this child will be out of either acute care or an emergency department. Okay, next. So WHO came up with a 10-point management. If you read most pediatric textbooks or the IMAM guidelines, or the guidelines that were developed by the Makerere Pediatrics Department, there is something called a 10-point management plan. And in it gives you 10 points and breaks them down into stabilization phase and the rehabilitation phase. So the stabilization phase, which I'm going to really talk about, is days 1 to 2 and the preceding days 3 to 7. So when you look at it, you find that number 1 to number 3 are the things, and number 5 are the things that are going to kill these children a lot earlier than sensory stimulation, okay, or micronutrients. So I'm going to basically concentrate on those 3. Next. Next. Okay, so the first one is, so you should know the child might come with the condition or might develop it while on the ward. So what we want to do is to either treat it or prevent it from happening. So hypoglycemia is one of those things. I'm guessing each one of us on this call can define hypoglycemia. And in this case, you're going to define it as a random blood sugar that is less than 3 millimoles. So hypoglycemia is one thing that is very preventable, very treatable, but can kill your child or our children or even adults in a very small period of time. So most times, children who come to the acute care unit, some of them have traveled distances, so they've not had anything to eat while on the way. As Dr. Kobe was telling you, some of these children don't actually have appetite to eat, so they've not basically been fed. So for any child who comes in and they are lethargic, or they are looking weak, they are looking sickly, they are unconscious, or they are convulsing, please suspect that they have hypoglycemia. I know in certain centers, we may not be able to get the glucose sticks. It won't kill you if you give this child glucose, okay? It won't kill the child. It will actually save them. So whether you have the glucose sticks or not, please give the child some glucose. And this is how we are going to give it. So for every conscious child, and you suspect or you diagnose hypoglycemia, you can get 1 rounded tablespoon of sugar and put it in 50 ml of water and give it to them by mouth. If you do not have sugar, you can give F75. That sister is going to tell us how you're going to mix it, how you're going to give it, okay? And this F75 normally should happen after you've given glucose, and then you continue every half an hour for the first 2 hours. So in case your child comes in and they're unconscious, they're convulsing, you're going to choose to give them IV dextrose 10% at 5 mils per kg. If you cannot access IV at that point in time, please insert an NG tube and you give them the sugar water, which is 50 mils by NG tube, okay? So repeat the random blood sugar measurements after 30 minutes. And if you're still less than 3 millimoles, you're going to have to repeat the entire process. Next. Prevention, so any child who appears to the malnutrition unit or to our IPDs or to our OPDs, let's try to give them a sugar, actually, I should put it. And like I said, you do not need a complex thing. You just need 1 round tablespoon of sugar, add it to 50 mils of water and give this child to drink if they can drink by mouth. If they can't drink by mouth, please use an NG tube. For every child who develops hypothermia, or they have defined or diagnosed septic shock, always assume that they have hypoglycemia as well, and give them an extra bolus of sugar. Next. So the other thing is hypothermia. Like Dr. Kobel told you, they've lost out on their fat. Remember, fat underneath our skins keeps our body warm, and our bodies or the body functions require a certain described temperature for them to perform adequately. So when you do an auxiliary temperature, which most of us do, and you find it to be less than 35 degrees, or a rectal temperature of less than 35.5, please, this child is hypothermic. You need to feed them immediately. You need to give them the F75. If there are children who still wet their panties or still wet the bed, you have to take out the nappies, the pampers, everything that is cold or wet, and get them new warm clothes. For children who are 1 year and less, you practice the kangaroo mother care. And then the room where you're going to nurse them from should be drought-free. Try to try to close the windows. And we discourage using hot water bottles because they can easily burn the fragile skins. So do not get hot water bottles to warm the child, but just close the window, cover them up. For those who are breastfeeding, encourage the mother to take warm fluid so that as the child is breastfeeding, they can share the mother's warmth. Then give appropriate antibiotics and always remember to treat for hypoglycemia. Next. So the other thing is dehydration. Now, most children with severe acute malnutrition and have edema are actually overhydrated, and they are less frequently hypovolemic. But in our thinking, sometimes they come in and you think, oh yeah, they are dehydrated. They are in shock because they have all these cold extremities. Their cup refill time is usually prolonged. So the overzealous people will think they are actually in shock and dehydrated. So we are saying children with severe acute malnutrition and they have edema, you do not give them IV fluids. You're going to kill them instead of saving them. So if your child is having edematous severe acute malnutrition and has definite profuse watery diarrhea, this is according to the mother and what you have witnessed. And you see the child is deteriorating, that's in terms of level of consciousness. You're going to replace the lost fluid through watery diarrhea using 30 mils of Resomol. Resomol is a specially prepared oral rehydration solution for children with malnutrition. The contents of sodium, potassium, magnesium are totally different. They've been cut down to match the needs of children with severe acute malnutrition. So immediately you finish giving the Resomol. Resomol is an oral solution. It's not intravenous, it's oral. You're going to have to reassess the clinical state of the child. If the child is showing features of heart failure, like the edema is worsening, they are getting difficulties in breathing, their level of consciousness is actually changing, it means you have over-rehydrated this child. Stop the Resomol. Please don't give diuretics. Okay, next. Okay, so this was going to be too much to put in one slide, so I cut it out from the management of malnutrition, according to the guidelines made by Makere that are used at Manamu Gym. And that's specifically for treating a child in shock with severe acute malnutrition, but they do not have edema. So this is clearly a red zone. It's showing you things are not very good. And you have a child who is lethargic or they're unconscious, they have cold hands, they have a slow capillary feel, and they have a weak or fast pulse, and you can evidently see they are dehydrated, their skin turgor returns very slowly, they are unable to drink. You're going to define this child as a child with dehydration with shock, and immediately you're going to get an IV line and give them 15 mils per kg of half-strength Dallows. Now, in malnutrition, things are quite different. We do not use normal saline. I'll show you in the next slide. The fluids are distinct. It's either Ringer's lactate with 5% or half-strength Dallows, but you don't go in and give your normal saline. You're going to kill the child. So if you give the first 15 mils per kg in 1 hour, and then you reassess your child, you find out that their level of consciousness is improving, their extremities are getting warmer, and the capillary feel might have improved to about 2. Stop your IV fluids and continue giving this child Resomol at 10 mils per kg per hour, okay? If the child is better, like the cold extremities have improved, the pulse is getting better, but they are still not alert. That's their level of consciousness is still very low. We shall now need to repeat the initial 15 mils per kg. So these slides are going to be shared. You're going to read through them. Some of them are pinned up in your facilities. Okay. Another. So those are the fluids I was saying. So we use Ringer's lactate with 5%. Half normal saline with 5% or half-strength Dallows with dextrose 5%. Next. So this is for a child with some dehydration and no dehydration, how to manage them, how to recognize that actually they have dehydration and not in shock. So this is a child with a history of significant fluid loss that's most likely through diarrhea. Then the mother may tell you, my daughter's or my baby's eyes are so prominent. They are quite sunken. So you go ahead and assess the child for symptoms of dehydration. And if you diagnose dehydration, this is a child you're going to give Resomol at 10 mils per kg per hour for the first 2 hours. You can do that orally or by NG tube and adjust according to weight. So immediately you get the patient to your facility, you've taken their weight, that's going to be your starting weight. Now, why do we want to do weight measurements every after rehydration? If you've over-rehydrated a child, they're going to abnormally gain weight. But we don't expect someone to gain weight if you've replaced what they've lost. So if you're gaining weight after your fluid resuscitation, either orally or IV, please think you may be over-rehydrating this child and they actually do not need your rehydration. Next. So there is septic shock. So like earlier on mentioned, these children are at a higher risk of infections and they'll easily progress into sepsis and septic shock. And if you get a diagnosis, so septic shock is the signs of shock. That's the reduced capillary fill. The extremities are not going to be cold, they are most likely going to be warm. Usually there is a focal site for infection like skin dermatosis. And if you've given your child fluids and they are not coming out, you're going to have to diagnose septic shock. And you're going to start with broad spectrum second-line antibiotics like cefotaxime. You're going to, after assessing if your child is not improving, you can add Cipro or gentamicin. And as you're doing that, prevent or treat hypothermia and hypoglycemia. Okay, so for septic shock, we can use fluids, but remember the fluids are only and only for patients or children with some without edema. So an unconscious child who is lethargic, you want to give them 10 mils per kg of Ringer's lactate with dextrose 5% in a ratio of 1:1 in 1 hour, and look at them every 10 minutes for signs of over-rehydration. And if they are conscious, they can be fed orally. Please don't give them IV fluids, give them F75. So the reason as to why we are saying no fluids in children with edema is their hearts are already overstrained with the excess they are having. So if you give them more fluid, you're going to send them to their early grave because whatever you're giving is not going to be, it's not matching the rate at which their heart is putting it out through the kidneys. So you're instead going to load them further. Okay. So as soon as your child improves, that's their level of consciousness gets better, they are able to feed, stop all the IV fluids and just continue with F75, either by mouth or by NG tube. Next. Okay, so just like the case we had, children with malnutrition can present with severe anemia, and this is defined as anemia less than or NHB less than 4 grams per deciliter, and this should be in less than 48 hours of admission. So if you have a child with NHB of less than 4 grams per deciliter, and you want to transfuse them, if you're using packed red blood cells, you're going to use 5 to 7 mils or 10 mils per kg of whole blood. And this should be done very slowly over 3 hours. In edematous children who cannot sustain the whole 10 mils per kg and everything, you're going to have to do exchange transfusion. I haven't done it before. I don't know if we have. Does Roswell have facilities for exchange? Yes. Roswell has facilities for exchange transfusion. So don't refuse to send, yeah? Send the children. And always give furosemide 1 milligram per kg when you're transfusing. Give them a rest of at least 3 hours for really their body to adjust after whatever you've given them. And you can feed them at least 3 hours later. Thank you for listening.
Thank you so much, Dr. Connie, for that wonderful presentation. In case you have any questions, please keep them coming. The Q&A question, they're going to be responded to. before we go to the next presenter, in case you have any burning question, please type it in the chat and they respond to it. Since we have no question currently, please keep them coming as we move the next presenter. So next on the agenda, we have Ms. Lois Atuhaire, the area manager of Mwanamjimu unit in Mulago. Yes, Lois Atuhaire.
Okay, as we continue. Thank you, everyone. Thank you, Dr. Connie. Thank you, Dr. Esther, and the guest presenter, Dr. Liza. So we are going to continue and proceed. We are going to look at the nursing and nutrition care for a child with SAM. I hope by now we all know what SAM means, severe acute malnutrition. And when we talk about severe acute malnutrition, Dr. Esther talked about it. We looked at it as when somebody has a Z-score of less than -3 or when there is severe wasting. Basically, SAM is a life-threatening condition that is characterized Okay, SAM is basically a life-threatening condition that's characterized by that kind of malnutrition where we have severe wasting, where we have oedematous malnutrition, where we have the Z-score, which is less than -3. You find that the weight for height is low. The child is tending to be more severe when we use the Z-score, the WHO Z-score. And Dr. Esther talked about the causes. We talked about the inadequate intake, the infections, the poor feeding practices, the social factors, and lack of healthy access, which can contribute to malnutrition. Next. So what do we think? Why do you think we need to integrate the nutrition, the nursing part, the medical part into the care of these children who are malnourished? One, we need to offer a holistic approach, because when we combine this care, that means the medical care, the nutrition care, we are able to address both the symptoms and the underlying causes. It's not a one-way thing. We have to come together as a team. And this will help in improving the recovery rate, reduce the mortality rate, and support the long-term health care, because it's not a one-way. So to us as nurses, or to anyone who is within the facility, your role as a nurse, one is assess. Assessment is part of you. When we talk about assessment, they already talked about it. We need to take the weight, we need to take the height and the MUAC. Weight is measured 1 hour before feeding or 1 hour after feeding, or every new patient you get at the triaging area. And height is measured like the way Dr. Esther talked, for children above 2 years. For less than 2 years, we say length. But if you don't have a length board and you have a height board, or if you have children who are stubborn, you're going to take length, you're going to take height and then subtract 0.7 to make it length. Then also do more like the way Dr. said. Then you need to check for oedema and other signs of malnutrition, like the way she talked about. The other signs of malnutrition is the clinical picture from head to toe. Dr. Esther talked about it. Then the immediate care we offer. One is to stabilize the children. Dr. Kon talked about the management of the medical complications. One thing as a nurse, you need to handle the hypoglycemia. Give sugar, water. if you're in a facility, you will not fail to get at least a teaspoon of sugar. You have the sugar you use to take your tea, you can manage to stabilize this child by giving sugar water to any child who approach your facility. Then you also manage the hypothermia. Hypothermia, you give extra coverings. So then we also talk about as nurses, you're supposed to administer prescribed antibiotics. If the doctor prescribed antibiotics, what is your role as a nurse? Go ahead and administer antibiotics. Then you also monitor these children. You start off the therapeutic feeds, because we have different phases of management as we are going to look at them. So the immediate care basically is to stabilize the child by looking at the medical complications. If there is diarrhea, that rhizomo. If there is hypothermia, offer the extra blankets, coverings. If there is hypothermia, sugar water, and then we administer the prescribed drug, then we start the therapeutic feeding. Next slide. Then we shall, as nurses work, we are going to monitor these children. Monitoring starts away from, it's regular, it's not a one thing that you're going to do now and then you're going to do it tomorrow. Monitoring should be regularly, because this patient, MDG, they were offering blood transfusion. What is your role as a nurse? Your role as a nurse is to monitor this child while the child was on blood. You're going to, before the blood was given, this child's weight was supposed to be taken by the nurse. The pulse, the respirations were supposed to be taken. You calculate the target weight, then the blood is set off. And you also have to cancel the mother. Remember, we need to not to give extra thing when the blood is given. That's why we have to monitor regularly. We are going to monitor the weight and we are going to monitor the health of this child. Health, we are meaning the vital signs. We are going to monitor all other parameters. Then another thing we are supposed to monitor is the feeds. Adjust nutrition based on the progress. You remember, we are not supposed to overwhelm this child's system. Like the way Dr. Kobel talked about, they have that, the pathophysiology, it's overwhelming. You don't want to overwhelm the system. You're supposed to adjust these feeds according to the different phases of management. And then another thing, as a nurse's role, you're supposed to educate the mother. You're going to educate this mother about the feeding, because when they come in, they are a little bit stressed. They don't know what to do. So you're supposed to be slow, educate them. Don't assume that they know everything, and you tell them about the warning signs, that like the children vomiting out everything, like the fever, like the convulsion. So you tell them about that. Then you offer also psychosocial support. So when we go back now to the nutrition care strategies, these children, we are going to manage them in different phases of management. We have the stabilization phase, which is our first phase in management. During the stabilization phase, these children that is the phase immediately they come in from the emergency unit, that like that Dr. Kobel said. So in stabilization phase, you're going to, if the child has diarrhea, we are going to give rhizomo. And rhizomo should not be freely given, because you don't want to overwhelm the system. Anything that during the stabilization phase, they have their systems are still weak. So you're going to give rhizomo when they have watery diarrhea or abdominally loose stools. And we are going to give, if there is no dehydration, we are going to give according to the age. If there is dehydration, so we are going to give 10 mils per kg per hour for the first 2 hours, like the way Dr. Kodels explained. Then we are going to start these children on therapeutic feeds. And usually our starter formula is F75. It has low kilocalories, it has low proteins. Usually you don't want to overwhelm the system. To start higher, you start low and then you continue to progress slowly by slowly. And the reason as why we give F75 is to promote to promote and repair the physiological and the metabolic function and the electrolyte balance of the patient. That's why you have to offer the F75. It is our starter formula for children 6 months and above, and should be given every after 2 hours. So this is our F75. So a previous in the other slide. So that is our F75. There is a slide on how F75, the tin and the composition, somehow they are there. It has low proteins, of which the protein in the F75 is 0.9 grams, and it has 75 kilocalories per 100 meals. So it is there to stabilize the patient. You don't expect any weight gain while on F75. It is for children 6 months and above. So when you're stabilizing this child who is less than 6 months, what do you give? Children who are less than 6 months without edema, we are going to give them SDTM. SDTM is specially diluted therapeutic milk. So it's basically got from F100. And if this child who is less than 6 months had edema, you're not going to give SDTM. You will also start with F75. Okay, hope we are together. So from that, these children should be in stabilization phase from 1 to, depending on the progress and how the cooperation between the caretaker and the health worker, because sometimes when this child is on F75, you're not supposed to give any other feed apart from F75, because these children are going to get refeeding syndrome. So basically, this child will be on F75 or SDTM alone, but those who are breastfeeding, they will continue to breastfeeding. F75 will be given every after 2 hours, day and night, while SDTM will be given 3 hourly. Proceed. And when the child now is recovering, remember every day we are taking the weight, we are monitoring these children, and we are the doctors are reviewing these children, medical complications are resolving, the child's appetite is back. Like now MDG, the child is stabilizing. That's when you say that now I can transit. Because from one level, you go to another level. Because formerly, we didn't want to overwhelm the system. We wanted a feed with low kilocalories and low protein. But in transition phase, it's where we want this child to gain some weight. So basically, we are going to transit, if the child is above 6 months, we are going to transit with RUTF. So long as the medical complications have resolved and the child's appetite is back, we shall ask for acceptance test and we shall give RUTF, which is ready to use therapeutic food. And it is given according to the body weight. We shall not give this child a whole sachet to eat. The reason that's why we start with RUTF, not F100, is RUTF can be taken to home and it shortens the length of stay in the hospital. Whereas F100 lengthens the stay in the hospital. You will not leave the hospital until we've reached the phase when you're out of danger, you've recovered from some. But RUTF, you take it and continue monitoring you in the outpatient clinic. But if this child fails to tolerate RUTF, that's when we shall proceed to F100. They all have the same nutrient density. They all help in achieving the catch-up growth or repairing the lost tissue. But you have to continue monitoring this child while this child is in transition phase. Transition phase is basically for monitoring. This child stays in transition for about 3 days. You want to see, is the child stable, can he tolerate going to the rehabilitation phase, where the rehabilitation phase can be managed even in the outpatient clinics in the OTC. If the child fails to tolerate RHF, you put this child on F100, which has high kilocalories and high proteins. It has 2.9 grams of protein and 100 kilocalories per 100 meals. So you're supposed to take the weight daily. If this child is not gaining weight while on RITF, then you will need to think through with the whole team, the doctors, the consultants, everyone need to come and re-evaluate the child. Because if the child, the new guideline says, if the child is not gaining weight on RITF, first introduce, leave RITF, go for F100 and monitor, and then go back to RITF. So basically that is that, and then you continue checking on the child, and then we involve in the sensory stimulation and play, because remember, a child who does not play will not improve faster. So we encourage the mothers to play with the child, with their children, even us as health workers, as you're moving around, health nurses, we need to play with the children, communicate. Play does not mean that you go and buy toys, go and, because there are studies which have been even taking place in Manamjim. We cut boxes and then we make them toys, and these children, they stimulate the brain, because when you go back to what Dr. Kobel talked about, the pathophysiology, that even the mental status, they get brain retardation, they get mental retardation. So you need to stimulate the brain. Another slide. So after you've now stabilized your child, now remember we started stabilization, then went to transition. Now our child is out of danger. So we are going to our last phase, which is the rehabilitation phase. In the rehabilitation phase, there is obviously ongoing nutrition support depending on the age. Basically, when we talk about rehabilitation, that means we are no longer on F75, now rehabilitation phase. Our children are out of danger, the immune system now are back, medical complications have resolved. Now these children should be transiting now to the normal foods. But our transition should be gradual. You don't want to overwhelm the system. So as we transit now basically to the community, so less than 6 months, they will continue breastfeeding exclusively, and then these children should be gaining weight. But those who are not exclusive breastfed, we are going to give other alternatives, supplementation, which are medically recommended. Not everything is medical. You don't, because children who are less than 6 months should be exclusive breastfed. And unless there is an issue, or it's medically recommended, that's when we shall go ahead. But as we are educating these mothers, we are not going to tell them to go and buy cow and get, because somehow it's very expensive. We shall educate them based on what is available. Like now, this MDG, they were supplementing with cow's milk, but our dilution was not right. 1 cup into another. That means this child was taking actually watery milk. And this is a leading cause of malnutrition in this child. And there was also early supplementation. So the combination led to malnutrition in this child. So basically, as we are trying to discharge these children, as we are trying to transit them to the community, we need to talk about what is that medically recommended if the child is not exclusively breastfed. By the way, we can even relactate if this mother had stopped long time ago. We do supplementary suckling technique. We make this mother breastfeed again. Because breastfeeding is natural. You counsel the mother, both psychologically, is she willing? Then you relactate. If she cannot, then we offer other recommendations using IYCF or the MICAN guidelines. IYCF is the infant and young child feeding policy or the MICAN guidelines, how to go about it. Then children who are above 6 months, now here it's when we are going to go about the locally available foods, where we're going to give the chitovero. Chitovero is where it's a combination of the mixed foods, where we have the gulo, and grow foods. We have the animal protein, a plant protein, and a carbohydrate. We usually teach these mothers on how to cook, how to prepare the chitovero, because by the time we discharge them from the hospital, they should be able to prepare these foods by themselves. Because like your child, your palm feeds your own child. If you're preparing the posho, then you're putting in the beans, then you're going to put in a silverfish. So you teach them based on the locally available foods. You will not tell this mother, go and buy this, when you yourself, you cannot manage it. And so we do nutrition education, we do health education talks every day. Basically, the leading cause of malnutrition during the stabilization phase, the mothers are not able to pick up. So as you're talking, as you're teaching them, somehow the minds are, will my child be okay? So you keep teaching. But in rehabilitation phase, the child is already out of danger. So the mother will be able to listen to you. As you're talking about the hygiene, because diarrhea comes in, and diarrhea can lead this child to malnutrition. So you teach this mother on how to be clean. We teach this mother on how to breastfeed their children, because a child who is less than 6 months basically should be gaining weight on breast milk. But what could be the cause? Could it be poor positioning? Could it be poor attachment? So we talk about that. And then we talk about how to prepare these foods based on that, what is locally available within their reach. And after all this, we shall discharge them. So as you're discharging them, remember, those who have been above 6 months old, we are going to follow them every week in our OTC, our outpatient clinics. Those who are less than 6 months, we shall follow them in our breastfeeding clinics. Those who are in above 6 months, we shall give them rations of RUTF and follow them up, those who were able to tolerate the RUTF. But those who failed, we shall continue teaching them using local available foods, how to enrich the high energy porridges, how to prepare their foods. And then we monitor them every week in the OTC clinic until they have gained the exit criteria. Exit criteria, we are aiming at weight for height, which is above -2 standard deviation. We no longer have that target weight gain and the rest. But while this child is on F100, our target weight gain per day is 8 grams per kilogram per day. And then we have to continue with our community engagement and support. Though in our central Uganda, we don't have community, but in upcountry, you have community supports. And then the WFP supports you there, so you need to link these children if you find them within there. And I will conclude by saying nutrition is a cornerstone of effective nursing care. So if you integrate all the care, nutrition, pediatrician, doctors, nursing, and they all come through, it is a very good idea in integrating, because there will be thoughtful nutrition assessment and intervention. It will be clear to intervene. Everyone will be on board to help this child recover quickly. Thank you so much.
Thank you.
And our key take home is we need to foster collaboration between nurses and nutritionists. We need to always update everyone, all the staffs with the new guidelines, because now, recently, there is a new update of the IMAM guidelines. We had 2020, 2021, but now WHO has, there is a new one which is on board, and still they are still validating on how to integrate it into the Ugandan context. And we also need to always educate mothers with clear resources on nutrition.
Thank you so much, Ms. Lois Atuhaire, for that very wonderful presentation. Next on the agenda, we are going to address some of the questions that have been posted in the Q&A section. Some of the questions are, someone was asking, what are the Chitobero foods? How often should they be given? And how is it prepared?
Okay, thank you so much for that wonderful question. The Chitobero is the locally available food, or it's the mixed food. Chitobero is the Ugandan word, but in English, the mixed food. It has the animal protein, it has the plant protein, and it has the carbohydrate, all mixed together. You know, children are picky. You don't want them to remove the bean and put aside. So when you're making this chitobero, if you're making an animal protein, will be either silverfish, or will be fish itself, or will be chicken, it can be an egg, it can be milk, it can be beef itself, meat. So that is the bit of the animal protein. Then the plant protein, cowpeas, beans, nuts, and that's the common ones in Uganda. Then the carbohydrate, we have the rice, we have the posho, we have the matoke, we have the yams. There are so many carbohydrates in Uganda. We have the Irish, all those. So your child, your palm feeds your own child, not my own, but or another one. It's your palm. So you make, if you're making a feed for lunch, you're going to make a palm of carbohydrates, a palm of plant protein, and if you're making it with silverfish, it has to be a teaspoon, because silverfish is somehow bitter. And then you put a pinch of salt in the same tiffin. You cover, you put some water, and then you cover. Make sure that when you're cooking a child's food, it should never be heat. You're killing all the micronutrients. It should be steamed. That's how we make the chitovero. So if the child is going to feed at midday, you put it as early as 8 a.m. By midday it will be well, and then you remove, then you mash everything together. And the child should feed 5 times a day, but that there are 2 meals. In the morning should be high energy porridge. Between morning and midday should be a fruit of their own choice or a snack. Then at midday, the child should eat the mixed food or the chitovero. At 3, high energy porridge. At 6, the child should be eating again. So that the 5 times we are talking about.
Thank you very much for that response. Another question that we had, someone was asking, how is dehydration diagnosed in malnutrition, and what are the major signs and symptoms to be noticed in a child with dehydration suffering from malnutrition?
Okay, so just like any other child, normally we are going to ask the mother. The mother gives the best story. So we're going to ask the mother, how has your child been? And she's going to tell you, today I've seen these eyes have dropped in, okay? This child is eagerly drinking or wants to drink. When they look at a cup, they want to drink. When you do the skin pinch, the skin will return very slowly. No? The skin will return very slowly, which means dehydration. In edema, in some with edema, these may not be present. And so we assume they are rarely dehydrated or hypovolemic. Thank you.
Okay, thank you, Dr. Baluka. Just to add my voice and to be more specific, so with children in malnutrition, they will already have a slow return of skin pinch. So it is not very helpful in assessing their dehydration status. So the important history is a child who has had history of volume loss. So they're having severe diarrhea or they're having vomiting. And we have a chart in the malnutrition ward which says number 1 stool, number 2, number 3, number 4. Number 1 stool is stool that is watery, so you literally can't differentiate it from water. And that is the kind of stool that predisposes these children to dehydration. Stool consistency number 2 is something that looks a lot like porridge. It has less risk of dehydration. So for you to say this child has dehydration, they have to have that clear history of volume loss, so vomiting, diarrhea, but then also they are eager to drink, or their eyes are a lot more sunken than they have been. So you ask the mother, and then she will clarify for you whether the child's eyes seem more sunken than they were before. For children with edematous malnutrition, we assume, if we think they have volume loss and they are lethargic, we assume we don't actually grade dehydration in that group. We just say manage shock in those children. Yeah. Dr. Brian has a question.
Yes, yeah, so however, what is most importantly assessed also in these severely malnourished children on ward, just on top of what Dr. Cogbel has been submitting, we also always look at their scalp veins. We want to see if they are visible or if they are not visible. That's also a very key point in assessing malnutrition in these children. Yeah, so if you find that their scalp veins are not visible, then we assume they are dehydrated. And of course, they should be having history of volume loss, just like she said. Yeah, so thank you.
In case you have any more questions, you can raise your hands and we select you.
Okay, so I think in the interest of time, I'm going to just go ahead and answer some of the questions that were raised to me. There was a question on the significance of vitamin A. So we do not routinely give vitamin A in children with malnutrition because it is already there in their therapeutic feeds. They have the dose that is sufficient for them. But for those who have obvious signs of vitamin A deficiency, so they have eye changes, those are the ones who benefit from a higher dose of vitamin A. So you give it at day 1, day 2, and repeat the dose, a third dose at day 15 of treatment. And the dose is given depending on the child's age, whether 5,000, 50,000, 100,000, or 200,000 units. Then another question on edema as an indicator of severe acute malnutrition. Yes, edema alone can be used to assess presence of severe acute malnutrition, of course, with relevant history that accompanies. So you have a child who obviously has social family history challenges, they have nutritional challenges, and then you have edema, bilateral pitting edema, to be more specific, can alone help guide you. Because in most of these children, their MOACs will be normal. So it will not be very informative to rely on MOAC for their measurements. But they may also have, but also their weight for length may also not be reliable because initially they have that weight because of the edema. So that is why you can rely on only edema to grade them. Then the question on why we do not measure in children less than 6 months the MOAC. Well, it's more of there's no reliable data that has looked at like the efficiency of using the MOAC in the children less than 6 months. So it's not reliable. All the studies that have been done have had poor reliability and poor prognostic ability to identify these children malnutrition in this age group. And then lastly, there was a question on giving iron infusion in these children with severe anemia. No, we don't give iron infusion routinely. We don't give iron infusion actually because we know iron is a good medium for growth of most bacteria. And yet already these children have a very poor immunity. They're already susceptible to so many infections. So if you give them something where an infection can grow, you're really just going to push them into septic shock in a very short time. Thank you.
Thank you very much. I have seen Andrew Oriel, you've raised your hand. Yes, you can unmute and speak.
Good afternoon, members who are on call.
Yes,
Andrew. I hope you're getting me well.
Okay,
Am I loud?
There. How about Asekenya Jennifer? I saw your hand raised up.
Yes. Good afternoon, everyone. Hope everyone is hearing me. Hello?
Hello, you are clear. Proceed.
Oh, okay, thank you so much. I also wanted to raise a question on the other concern of the edematous child, especially sometimes when we are managing children with edema. When we initiate them on F75, at most cases, you find sometimes when the child is gaining weight, yet in stabilization phase, we are told like the child is not supposed to be gaining weight while on F75. So in such a scenario, what should we do in case the child is on F75 and is gaining weight? Thank you.
Thank you so much, Jennifer. Thank you so much, Jennifer, for that wonderful question. Usually, when in stabilization phase, the children should not gain any weight. But if you find this child who came in with edema and is gaining weight, that means they are giving other feeds on top of the F75. So we are getting refeeding syndrome. And this child who is given any other thing will not heal faster. If you find that the edema is increasing, you need to go ahead and investigate what could be the leading cause. You need to ask the mother, is she giving any other feed on top of the F75? If not, then you need to go ahead and investigate, because sometimes if they are not giving any other thing, maybe refeeding syndrome comes in if they are giving extra feed, because now there will be too much proteins coming in from left and right. Remember, F75 has low protein, has low kilocalories, but they are giving extra kilocalories from other sources, and this child is getting refeeding syndrome. So you need to go ahead and investigate and ask the mother and do other investigation, RFTs, LFTs, to rule out what could be the other leading cause that can make this edema to increase. Thank you.
Thank you so much, Ms. Lois. Our last question: why is there ciprofloxacin used in the management of septic shock, yet cipro is contraindicated in children below 12 years?
I have a question, please.
It's okay, you can speak.
Okay, good afternoon, everyone, and thank you for the presentation. I wanted to know the pathophysiology of edema in malnutrition. Like, how does it come about? Thank you.
Hi, can I ask a question? Good afternoon. Thank you very much. We have seen a lot of cases in the world for malnutrition cases and diabetic, type 1 diabetic, sometimes with the DKA episodes. So how can we manage a patient with severe acute malnutrition and diabetic status? Thank you. Also with renal failure, also we have seen a case with renal failure and SAM.
Okay.
Any other question?
Good afternoon. I hope I'm clear. Am I being heard?
Yes, please.
Mom, thank you. I have one. When they were managing shock in malnutrition, I heard doctor talking about giving fluids and how to monitor this fluid. They were just like, when you give fluid, you should not keep close monitoring, but the aspect of setting a target weight for monitoring the child's weight was missing. I think, doctor, you can elaborate more on that. And then at what age, because, according to our Uganda clinical guideline, and Cipro is supposed to be given from age of 12 years and above. So I don't know whether there's any already an updated whatever on Cipro, then you can also make us know. And on edema, there's easiest way of getting edema. One, edema nutritional edema has 3 categories. One, it doesn't change with the time of the day. Two, it has to be bilateral. And 3, and it should be pitting. So somebody who is doing that should factor in the 3 characteristics of the nutritional edema. I think that is it. And sometimes we always get referrals from people who are working in the clinic after even seeing that the child is wasted. Some of them can decide to give ORS and also put their normal saline to the child and refer a child which is child now will be doing bad. Then some clinicians also, after identifying that the child is having edema without assessing for malnutrition, just give the diuretics to these children. So I think it is a key note that I think nutrition is a wide field that should be integrated. Thank you so much.
Okay, thank you. I think let me give Lois a chance to.
Thank you so much for that presentation. So next on the agenda, there is a link for our post test. It's going to show up in the chat. Please tap on it and go through those questions as we continue.
Thank you so much for all the questions. I will respond to one whereby during the management of shock and all. So before you give the IV fluids in the management of shock, we are supposed to first lay our parameters down. We are supposed to take the weight before rehydrating. You're supposed to calculate the target weight. Our target weight ranges from 3%, which is the minimum, to 5%, which is our maximum weight gain. You're supposed to take the pulse. You're supposed to take the respirations, and you should supposed also to measure the liver size, because you don't want to overwhelm you don't want to cause organomegaly. That's why you have to measure the liver size. So as you're rehydrating these children, the children who are in shock, you're going to be monitoring because they are going to be on the fluids for a period of 2 hours. The first 1 hour, you go and take the weight. You see, is the child gaining, have you achieved your target weight gain? The 3%. If you've achieved the minimum target weight gain, you're supposed to stop the IV fluids and then you continue your F75 every after 2 hours or the SDTM. If there is still watery diarrhea or the abnormal route, like the way Dr. Kobel said, you're going to give Rhizomo every after loose stool, but you're supposed to monitor. Then that is how we calculate the target weight. Our target weight ranges from 3 to 5%. But you don't only monitor the target weight, you also monitor other parameters like the pulse, the respiration. Because as you're rehydrating, if the pulse is going high, then this child is going into failure. You have to stop your fluids. Thank you. And another thing was, yes, on MUAC. In our country, we don't have MUAC tapes for children under 6 months. The tapes we have are for children above 6 months, but there is MAMI program, which is coming on. It's a research. If they procure those specific MUAC tapes for that age category, I think as the research goes on, then we shall be able to do the MUAC. Thank you.
Thank you, Lois. I'll start with a question on use of ciprofloxacin in children. It's not an absolute contraindication because the worry with ciprofloxacin in children is previous studies did show that it can cause a bit of musculoskeletal side effects, specifically articular damage. So we do not routinely use ciprofloxacin. First line remains ampicillin genta. Second line is third generation cephalosporins, ceftriaxone, one of being an example there. So unless we have failed is when we proceed to use these other antibiotics like ciprofloxacin. So it's not an absolute contraindication, but also always remember that there are side effects, especially in children, and you have to be very cautious in use. The pathophysiology of edema, like I mentioned earlier, is not clear. It's not been well studied, and there are really speculations here and there. One of the theories talks about hypoalbuminemia, but even when they looked at children who had hypoalbuminemia and those who did not have, there was really no difference. There was no significance when they compared the two groups. So that is still an area that is being studied widely. Then the last thing that I'm going to talk about is renal failure and severe acute malnutrition. We've seen that children with severe acute malnutrition are at risk of, they're at risk of diarrheas and volume loss. And we know that when you have reduced volume loss, of course, your renals are not getting up. So they end up a lot with pre-renal failure. So that is what we have seen happen more commonly in children who have severe acute malnutrition. They get pre-renal AKI because of volume loss. Okay, thank you very much. I will hand over to the chair, moderator of the session.
Thank you very much, our dear experts, for this session. So we have come to the end of our session. Though we have shared a CPD point link, please tap in and respond to it. So as we come to the end of our session, I'd like to request you all to turn on your cameras. We take a group photo. As we take a group photo, I want to thank the participants for logging in. I want to thank our dear experts for the knowledge they've shared with us. I also want to thank the Ministry of Health for the guidance, the doctors, the nurses, the midwives, and all the healthcare practitioners out there. Thank you so much for taking your time to log in and attend to this session. It was a wonderful session. Please turn on your cameras and we take a group photo.
Yeah, thank you, and thank you, moderator. Thanks, team. Just a communication to everyone else. Yeah, so our communication really to everyone here today with us. Our next session will be in 2 weeks' time, and it will be on diabetic emergencies. We shall be happy really to see all of you. Yeah, thank you so much for those who are evaluating our session. You can really click on any of those. It helps us to improve the sessions. We look forward to seeing you again in 2 weeks' time. Please keep on your cameras. We should be able to see.
Turn on your videos.
Hello, I have a
Yes, thank you for turning on your cameras. Thank you for attending that session. Please give us some smiles as we take